Hello, everybody. Thank you for joining us for the session four of today's rural conference. This session four is Protect Your Value, Positioning Rural Hospitals for Stronger Partnerships. Strategic partnership conversations are becoming increasingly common across rural healthcare, but many organizations enter those discussions without a clear understanding of how rural hospital value should be measured, protected, and strengthened. In this session, Jeff Summer, Managing Director at Stroudwater Associates, along with Claire Kelly, Senior Consultant at Stroudwater Associates, will share practical framework and rural hospitals can use to evaluate partnerships from a position of strength, drawing from extensive experience supporting affiliations, strategic planning, and operational assessments. Jeff and Claire will discuss how organizations can better quantify contribution margin, assess operational and strategic risk, strengthen government alliance, and approach negotiations with greater clarity and leverage. This discussion will also explore how rural hospitals can balance independence, sustainability, and partnership opportunities while ensuring the unique value rural organizations provide to their communities is fully recognized. Jeff, Claire, I hand it over to you.
Thank you so much, Amy. Really appreciate the introduction, and thank you all for joining us today. Claire and I will walk through over the next hour kind of our approach, which has really been informed by our experience advising rural hospitals on all types of partnerships over the last decade plus. And I'd like to just start by saying there are three key things we'd love for folks to take away from this discussion. The first is a recognition that most partnerships are suboptimized. That is, they don't reach their true potential value. And there's reasons for that. And in particular, the most common reasons for rural partnerships with non-rural systems are, number one, there's mistakes in assessing the value of the rural affiliate. So that basis, that understanding is either incomplete or incorrect. And the second most common cause for undervaluing or creating a poorly negotiated partnership is, frankly, mistakes in the process, mistakes in the negotiation, and not taking full advantage of what can be a way to structure this conversation or those negotiations in a way that is advantageous to the rural affiliate. So the third thing, and the most important thing, is that Claire and I are going to share some of the approaches that we found are proven for realizing or better realizing the value of rural affiliates. So those are the three takeaways. And with that, I wanted to share with you kind of a slide that summarizes kind of the journey we're all on. As folks that are either working with rural hospitals or working at rural hospitals or providing care at them. And basically, these are the five outcomes that we see. And they range from best on the right to worst on the left, worst being closure. We think that's typically a bad outcome, certainly for the organization, but certainly for the communities that hospital or health system serves. The best example is what we call thriving independence or interdependence. This is a locally governed, locally owned rural health systems that is adequately resourced and has access to the expertise and the capital and the personnel that it needs to be effective. Now, that organization can have partnerships, but the key point being that governance is substantially local. It hasn't been taken over by somebody else. We think that's the best outcome. The next best outcome would be a good partner or partnership. And this is one where the partnership has been designed and negotiated to reflect the actual value and potential value of the rural affiliate, and is actually creating value for both the parent and the affiliate. And so that's one where the partner is strategically aligned with the rural affiliate and is not using kind of predatory tactics, predatory strategies to extract value. Excuse me. The majority of hospitals that we see are in what we call strategic drift or purgatory. And this means they're not in a long-term sustainable position, but they're not necessarily at imminent risk of something catastrophic happening. And one of two things is happening when you're in that middle category. You're either improving your position, your market position, your strategic risk profile, your strength as an organization, your ability to serve your communities, or those attributes are being diluted and weakened, and you're becoming less strong, less able to do so. And so the important thing when you're in that purgatory, that strategic drift, is that you're moving in the right direction. If the market and circumstances are moving more quickly in the opposite direction than you can move to the right, then that suggests that that strategy isn't working for you and you need to rethink it. The next to worst outcome is a bad partner or partnership. And this would be one where the partner is perhaps predatory in some of their tactics, and they're unable or unwilling to recognize the value that the rural affiliate is bringing to the table, and unwilling or unable to actually implement some strategies that will create value for both the parent and the rural affiliate. Instead, they're they're doing things that are short-term focused and that improve things in the short run for the system. In the long run, those won't, but in the short run, they may. So that's kind of the range of outcomes. And what we obviously want to do in our practice is make sure wherever you are on that trajectory that we're moving to the right. If we're in the strategic drift or purgatory session, we want to be moving to the right and improving our strategic position, mitigating our strategic risks so that we're positioning ourselves for longer term sustainability and options in the future. So we've got our first polling question here, and we'd really like to understand our attendees what their partnership status is. So if you're in a partnership, how would you rate the performance of that partnership? High value, moderate value, mixed bag, limited value, or worst case, no value or destructive of value. And we'll give that a few minutes for folks to respond and look at those options. Give it another 5 or 10 seconds. Okay. Well, we can see that we've got about half people that would describe, or half respondents would describe high value or moderate value. About a third would say mixed bag. And then a much smaller 15% that would say limited value or no value or destructive of value. So interesting, and I think actually fairly positive outcome. So that's really quite helpful. So if I'm a leader or a member of senior leadership at a rural health system, what are the key things that I need to know? Well, our experience, and it doesn't dovetail with the polling results, is that most systems miss critical aspects of rural value. That's our experience, that those partnerships are sub-optimized in some material and important way. They may create value, but they're missing the boat in some respects. And one of the ways, and I mentioned this earlier, that value is failed to be realized is that folks don't understand the value proposition of the rural affiliate. And one of the things we would say to you is no one is going to stumble across your value if you are not able to quantify it and demonstrate it, or at least make a case for it to a system leaders. So it's really up to you or your advisors to help identify that value, quantify that value, and then ultimately operationalize that value going forward. You really want to identify win-wins with existing partners. That's really critical. And you really want a partner, if you're not in a partnership, that understands your value. And we talked about, and we'll talk about this some more, variable versus fixed costs and how those factor into an accurate contribution margin analysis. The fact that you do not want to allocate fixed overhead that will remain whether there's a rural affiliate or not. Those costs that would remain anyway are irrelevant to evaluating the performance of the rural affiliate. We want to look at incremental versus simply reallocated overhead. And we want to look at, among other things, the value of incremental referrals that come from that rural affiliate. So we call this the four no-nos. You need to know your risk profile. You need to know your value. No one else is going to promote your value unless you do. And lastly, there are no risk-free options. So a standalone strategy has an inherent risk profile, that one that you can mitigate with improved operating results. And a partnership has an inherent risk profile, really coming from partner risk. And that's one that you can also mitigate that set of risks through a good partnership process, options process. So, I want to talk a little bit about what folks get wrong. And this is an example of an affiliate. It's a was a seven hospital rural, excuse me, a seven hospital system that's subsequently been gobbled up by a larger system. But it included a 120 bed community hospital affiliate. Now, the system was allocating $25 million of overhead to the affiliate, and that allocation of overhead resulted in a $13 million operating loss. So this is where things start to go off the rails a little bit. As a result of that fully allocated set of costs and the $13 million operating loss, the system started rationing capital, and they were really taking a really negative view of the performance of that affiliate. Now, that operating loss included $7 million of depreciation expense, which is a non-cash item, and it excluded $3 million in non-operating income. So that $13 million operating loss was basically a $3 million cash loss when you included those two things after fully allocating all of the system overhead. But it's important to note, of that $25 million in system overhead, only 20%, about 5 million, was actually incremental overhead directly associated with that affiliate. So if that affiliate went away, $20 million of that overhead would remain. So from our perspective, the allocation of overhead should have been the 20%, the incremental cost that reflects the cost of that affiliate. So instead of having a $13 million operating loss, they would have had an $8 million, if I'm doing the math right here, let me just think about that, would have been a $7 million operating gain before talking about depreciation or non-operating income. So when you start to look at that contribution margin, on a contribution margin basis, it's about a $17 million gain. But importantly, one thing the system didn't look at is that affiliate provided $22 million in incremental contribution margin via incremental referrals that, in our estimate, conservative estimate, would not have occurred had they not had that rural affiliate serving that area. So the total positive contribution margin to the system from that affiliate was $39 million, yet the system parent was behaving as if that affiliate was bleeding them dry. And this is a scenario that we see play out time and time again. An analysis of the contribution by an affiliate that is flawed, incomplete, or frankly just wrong. So this is job number one to get right if you are evaluating your value as a potential affiliate or are in a system and they're evaluating your performance. So the waterfall of effects from this mistake, outcome number one, if you're negotiating a affiliation, the deal terms don't reflect your long-term value creation because they're looking at you using a flawed methodology. Adverse outcome two, based upon that methodology, they miss out on opportunities that are available and fail to account for rural accretive value that is available to them. And so, number three, chronic underinvestment. You saw that in the earlier scenario. And outcome number four, that long-term affiliate performance and system performance is diluted and suboptimized. And so this is, again, I can't tell you the number of times we've encountered really foundational mistakes in evaluating the performance of affiliates and how that then cascades through a set of decisions that then compound adverse outcomes. So something to be really aware of going forward.
Thanks, Jeff. So we're going to briefly touch on some health industry factors that we've seen to be increasing strategic risk for rural hospitals and critical access hospitals, and how they can really have some adverse outcomes for hospitals. Starting with the adverse outcomes, we've seen 201 closed or converted rural hospitals since 2010. And to specify what we mean by converted is hospitals that used to have an inpatient stay, so something like a critical access hospital or PPS hospital, no longer have those inpatient stays and have been converted to something akin to a rural emergency hospital. We've had 44 rural emergency hospital conversions occur since 2023, and those make up about 22% of the total 201 closed or converted rural hospitals since 2010. The top states with the most closed hospitals are Texas at about 13%, Tennessee at about 8.4%, and Oklahoma at about 7%. So there are a few catalysts in the industry that are driving this closure or consolidation, and I don't think many of these will be a surprise to folks. Number one is margin pressure. So when you think of the increase in salaries and wages and benefits, all the healthcare benefits that we've seen go up, again, that's really compounding that margin. Another big one is provider shortages. When you have physician shortages that are coming down the pipeline, we have a predicted shortage of 86,000 physicians by 2036. And currently 42% of the current physician workforce that's in the market is above the age of 55. So folks that are, expected to retire in the next 5 to 10 years, going from full-time to part-time is only going to really compound that issue for rural entities. And we're starting to see it hit different geographic areas harder, rural being the number one area that's going to be hit hard the most. And again, specialist wait times for recruitment are between 18 to 24 months for certain folks. So again, wanting to pay attention to those provider shortages. Staffing crisis is also a big one. So it's not only physicians and APPs, it's your nurses, your MAs, your janitorial staff, your cafeteria workers. All those folks are going to be increasingly more difficult to hire. And additionally, economies of skill. And what we mean by this is that there's a lot of minutia in rural healthcare, and getting individuals who can really understand that minutia and dive into the details around that is becoming increasingly more difficult. So how do you deal with some of these catalysts? What's a way to mitigate this risk? The number one item you can do is improved operating performance. So whatever you can do to have improved performance at your organization, no matter if you're an independent organization and looking to stay independent, if you're in an existing partnership or looking at a potential partnership, improved performance can only broaden your strategic options and only make you more sustainable in the long run. Stroudwater looked at 30 rural performance improvement projects that we've done over the past 30 months. And we found a median of 1.7 million in financial improvement per organization from that. And that's about 8% of net patient revenue per organization. And this improvement was identified across a bunch of different functional areas. I want to emphasize that these are all really growth areas. None of these were cutting of services or staffing reductions. Really, the number one driver was reduction in inpatient outmigration. So keeping patients local, figuring out where there were access issues, trying to understand what can we do locally or keep local that we're referring out, where there are gaps in access to care in our community that we need to provide. 17% of this improvement was driven by revenue cycle as well. So understanding how can we reduce days in AR and really get paid for the work that we're doing. I'll pass it back over to Jeff.
Thank you, Claire. What we want to talk about now is this question of timing. And the first thing to know is time's never a neutral factor. So, it seems fairly obvious, but why do we say that? Well, we say that because sometimes boards and decision makers can be in a mindset, well, we're just going to kind of kick the can down the road. We're going to keep our cards close to our vest. We're going to wait and see what happens. It's really important to understand wait and see means we're waiting for circumstances to change in ways that frankly may be unfriendly to us. And that can range from things like a great recession or a pandemic, but it can also be how the market evolves or how a key physician group decides they want to perform their role, or providers retiring. All of these things are factors that can have a significant impact in the organization's risk profile as it moves forward. And to Claire's point, operating results and the trend of those operating results also weigh heavily on impact on factors going forward. So really important to keep this in mind. And this is some interesting context here. This comes from a study we're doing on rural hospital closures. And the study has not been published yet. It should be published later this summer or this fall. And what we really based this study on was some great research done at UNC by George Pink and some of his colleagues. Very statistically robust and statistically significant. But because they were using, kind of an academic peer-reviewed statistical model, they really focused on trying to predict closure or financial distress and really could only do that 2 years out with statistical validity. We felt there were two limitations to their work. One was it was so statistics heavy that it became difficult to actionalize it or operationalize it. Let me use that word instead. And it also didn't provide enough lead time. And so one of the things we've really focused on is the period highlighted there, 8 years and 4 years prior to closure. So those numbers at the bottom, the negative numbers, symbolize the years prior to the year of closure. And so we looked at the years 8 and 4 years prior to closure to understand what is the trend of the difference between the median for rural hospitals that remained open, which is the gold line, versus the median for rural hospitals that closed, which is the blue line, significantly lower. And the lighter bar threshold there is the top quartile of rural hospitals that closed. And so you can understand why the statisticians, the academics, didn't have a statistically valid finding until year -2, year -1, because that's when you really start to see the gap from that top quartile of rural hospitals that closed from the median that remained open. But importantly for us, we wanted to be able to provide a set of benchmarks for management. And so we've looked at the absolute levels of, in this case, we're looking at total cash flow margin of median for hospitals that remained open versus median low, 8 years and then 4 years prior. And also the trend line over those 5 years in question to allow decision makers to say, do I look more like median performance of a rural hospital that remained open, or more like the median performance of a rural hospital that closed. And so this illustrates in a nutshell, though, why timing is so important, because the slide to a high risk situation, maybe not closure, but one where you are significantly compromised, starts significantly early, and the groundwork is laid very early. And so, to Claire's point in operational performance, the sooner you do that, the sooner you're able to mitigate adverse outcomes, mitigate strategic risk profile, and have a better outcome. So keep an eye peeled for this study, again, which should be out later this summer, probably most likely this fall, given some of the work we've still got to do on it. This is a more holistic framework for thinking about strategic risk. And we really think about strategic risk in terms of 4 vectors. Clearly, financial and operational are important, but market trends and also value trends, where you look at the interface between cost and cost position and quality, and the ability to manage lives and manage risk. All of that factors into that. But these various metrics, no one by itself, but usually in combination. And the same thing's true with the actual risk vectors. It often isn't just one risk vector. They can spill over into one another with time. But I would say one of the things in terms of understanding your risk, vitally important, not just to look at performance on these metrics versus prior year or versus budget, is to really look at 5-year or even 7-year trends. So understand how kind of slight but consistent trends, adverse trends, can really change your risk profile and create a much heightened set of risks and potentially adverse outcomes for the organization. And the converse is also true. The improvement may be subtle, but it does have the significant ability to mitigate your risk profile. So we've got another polling question here. Um, Curious, thinking about this strategic risk profile, how confident are you that your board truly understands your organization's risk profile? Are you extremely confident, confident, not very confident, not at all confident, or unknown or unsure in the results? So it looks like we're getting some more responses to this polling question, which is great. And we'll let that come in for a little bit here. Give it another couple seconds. Okay. With that, um, basically, it looks like about 40% is confident or extremely confident, 45% are not very confident, and then 10% are not at all confident, with a very small percentage, 3% unknown. So the good news is folks are confident or extremely confident in about 40% of the time. But this is one of those things where annually, at least a brief checkup to look at how do those 5-year, 7-year trends look like when we add the most recent year's results to that trend, and how has it changed is really important.
So, how do you ensure your partnership creates value, whether you're in an existing partnership or looking at a potential partnership? The first thing to understand is there's an array of different partnership structures, and one size does not fit all. As we move from left to right on this chart, we increase the degree of integration in terms of the partnership structure. So a clinical affiliation, you may have a system partner where you're working together on a couple different specialties, whether it's something like oncology or cardiology. And as we move down that trend line to the sole member substitution, that becomes where a critical access hospital or organization would be the sole member of that system and fall under that system umbrella. And that's really where the finances tend to get tighter and more tied together. So the different partnership structures can really impact the different what we call value levers available to your organization. And while we won't dive in depth into all of these value levers today, it's important to understand that systems tend to undervalue these items. Individually, each of these value levers is potentially significant, but when combined and working together, they can really change the financial profile of a rural organization to a system or an affiliate. So really important to keep that in mind. And it gets back to that minutia of knowing the minutia of rural healthcare, that we talked about previously. Again, systems don't not understand it because out of malice or ill will, it's just they aren't as familiar with the rural landscape as you may be. So it's really important that as a critical access hospital or a rural affiliate, that you are able to articulate these value levers. You, with an advisor, are able to quantify these value levers and demonstrate them to a potential partner. So a couple examples here. A home office cost allocation. So hospitals that maintain a system relationship and meet certain requirements may qualify for and include a home office cost allocation on the Medicare cost report as an allowable expense. And what this does is it allows for a cost sharing methodology that allows a partner to allocate overhead costs incurred for providing administrative services to a critical access hospital, which would allow for potentially enhanced system reimbursement. This is something that is really great to capitalize on as we get to those more integrated structures towards the right side of that system integration we were looking at. We can also look at what we call leverage sites of service, which gets at swing beds and decanting volume. And what we mean here is that lower acuity patients can remain at the critical access hospital or rural affiliate, and we can free up higher acuity bed space at the system partner. So for example, utilizing a critical access hospital for swing bed patients to refer patients who are finishing up an acute stay and still in need of post-acute care. Those folks can come from that system to the rural affiliate to stay. And what it does is it frees up an occupied bed for the next complex acute patient and reduces variable costs incurred from keeping patients longer under DRGs at that system affiliate. The last two bullets on this list are really important and tend to be ones that are really overlooked by systems. And the first is the value of attributed lives in a primary care base that is cash flow positive. And what we'd say here is this is really the system getting after the entire referral channel. The primary care base, as we know, is really the lifeblood of any critical access hospital. That is how you are getting referrals into your organization. Having a strong primary care base is so important for the sustainability of a critical access hospital. Systems want to be able to own that chain as it comes up to their higher acuity care, which gets into the true value of incremental referrals. We can go in and estimate the contribution margin based on change in referral patterns due to a partnership. So, for example, if a critical access hospital has 3 systems within its service area, it's referring folks who need a higher acuity care out to those 3 individual systems. Then that critical access hospital goes and partners with one of those 3 systems. Those referral networks are going to change. It's more than likely that more patients are going to go who need higher acuity care from that critical access hospital to that new system partner and not to the 2 competitors that are in the service area. There's a real financial benefit from that to the system, and being able to quantify that and use that in negotiations for a potential partnership or with an existing partner is really important for rural organizations. So how can we use these value levers, and where can you take advantage of them when it comes to different partnership structures? Again, you have to select your partnership structure pretty carefully to make sure you can take advantage of certain value levers. So for swing beds and looking at decanting volume, really, if depending on the type of relationship you have with your system, that can be taken advantage of really across any type of partnership, or something like a home office cost allocation, is going to have to be towards the right of that spectrum, something where it's a sole member substitution or a full-on asset purchase, again, something where the financials are more closely tied together.
And we wanted to share a little bit when we're talking about different options, partnering options, share a little bit about FQHCs, because this really seems like it's underutilized, but also highly opportunistic. And I think the Charles Dickens line, it was the best of times, it was the worst of times, applies to rural hospital relationships with FQHCs. These reflect ones where the organizations have been able to find a really high functioning collaborative working relationship. We recognize that that's not always the case. And in fact, we've seen more instances of hospitals and FQHCs being in a very low trust, dysfunctional, competitive type relationship. But that being said, when we talk about that right-hand set of outcomes, that thriving interdependence or independence, FQHCs present an opportunity to sustain that locally governed, locally controlled healthcare system, but potentially partner with a like-minded and value-added partner. And part of this is derived from the fact that FQHCs in many states receive substantially higher Medicaid payments for clinic visits than non-FQHC providers, including RHCs. Not true across the board, but the variances can be very significant. And FQHCs have been utilized for that reason to help, and others, to help sustain local labor and delivery programs. Now, a grandfathered RHC may provide enhanced clinic patient payment versus an FQHC. So it's situation specific. But the other thing to keep in mind when you're thinking about sustainable local labor and delivery program is the Federal Tort Claims Act relief that providers employed by an FQHC receive. So a significant portion of malpractice liability and cost is shed via having those providers housed at an FQHC. There's also an opportunity for Section 330 grant funding to help sustain that program. And again, such a partnership can be contractual in nature, doesn't involve, frankly, by by statute and regulatory structure, a change in ownership, but it preserves local ownership and governance. And you can have cross representation of some board membership and have a contractual arrangement that sustains that. But there are some constraints. I won't go through those. I think these are fairly self-explanatory, but it's important to keep these constraints in mind. I would just point out one that is, unless you're a public entity, 51% of the governing board of the FQHC must be patients of the FQHC. So that becomes a significant governance constraint in many instances. But there are ways to achieve alignment without having to trigger that particular issue. And just a couple more points here. There's an example in case study number one where a local hospital in the FQHC basically created a business relationship where the FQHC operated the primary care contractual arrangement, and they had cross representation on their boards, albeit nothing coming anywhere close to 51% board representation. The hospital focused on specialty care, hospital inpatient, outpatient care. The FQHC focused on primary care. This has been a long-standing, successful, sustainable model for this community and a real asset for, frankly, both the hospital and the FQHC. The next one is an adversarial relationship that they were able to overcome that. And so in this case, they actually created a really good collaborative model and even shared CEO time and some other time. But one of the things in this situation that they're looking to do is create a shared management services organization that would, by contract, provide services to both the hospital and the FQHC, but it would be a single entity doing that. So they would no longer have multiple IT platforms, multiple purchasing, marketing functions, et cetera. It would all be consolidated in one MSO that would be contractually providing those services to the hospital and the FQHC. So they've got the alignment now already, but now what they're looking to do is really eliminate a lot more duplication and kind of the administrative back office side of things. So a very interesting model there to really take an FQHC rural hospital collaboration to the next level.
Thanks, Jeff. So I know Jeff has mentioned previously that there's no risk-free option, and partnering is certainly not an exception to that. Whether you're an existing partnership or a prospective partnership, partnering is not a risk-free endeavor, nor is status quo or staying independent for that matter either. So how do you mitigate some of these risks and make sure that you're evaluating your processes efficiently and effectively? If you're looking at prospective partnerships, making sure you're finding a partner that is strategically aligned with your organization. Make sure your organization has laid out strict objectives of what they want to achieve with the partnership and understand, okay, is our partner willing to meet us at these objectives? Are they fitting what we've asked them to? Assessing their track record. Do your prospective partners have rural affiliates? Have they been good to their rural affiliates? Speak with those rural affiliates, understand if they've followed through on their contractual obligations and if they've been good partners down the road. Selecting that right affiliation structure and partnership model that we talked about, making sure that that partnership model that you select allows you to take advantage of some of those value levers we talked about. And finally, and arguably most importantly, is crafting contractually enforceable terms that reflect your value. And when we mean contractually enforceable terms, there's no weasel words in those commitments. So an example of a weasel word commitment would be commit up to invest $5 million in capital. Well, up to means they could invest $0 in capital and still meet those contractual obligations. So again, making sure you've minimized the weasel word language, and you also have a body at your organization to enforce the contract. You have someone or an organization, whether it's a small board or a foundation, an organization that is contractually allowed to enforce the terms that you've set forth with a potential partner. Existing partners, making sure your partner understands your value proposition. Again, making sure they're educated on your rural value. You've been able to sit down and quantify the ROI of the investments that reflect your rural value or performance improvements that you're doing. You've identified missed and any potential opportunities and kind of laid that out in front of them of, hey, let's moving forward. Let's use this as a foundation. How can we start to have these conversations? Kind of elaborating on that. How do you get them to sit down at the table, and what do you tackle first in those situations for existing partners? Number one is looking at the low-hanging fruit. What's low cost to implement, quick ROI, gaining that trust, being able to work with your system partner to kind of establish the building blocks of a stronger relationship. In many cases, this is something like the swing beds that we've talked about and shifting volume for lower acuity patients to the critical access hospital and keeping higher acuity patients at the system partner. Starting there as a building block and then building out into some of the more complex situations, whether that's looking at the contribution margins distributed to referrals or understanding the home office cost allocation or cost report improvements that again may take more time to implement, but you want to start to build that foundation of trust first. So this is an example of a health system that Stroudwater was retained by to work with. And this health system had 4 critical access hospitals that totaled about $55 million in operating revenue. And Stroudwater was brought on because this health system believed that these rural affiliates were, again, a drain on their operating results. And they wanted to look at an in-depth financial and operational analysis to figure out where there were potential areas for operational improvement. So when we dug into the data, we found that the operational and financial evaluation found a total of $6 million on an annual basis of missed operating cash flow improvement opportunities. So again, just from performance improvement opportunities, that was $6 million on an annual basis. However, we additionally reviewed and found $9 million in errors on the system's evaluation of the contribution margin of these rural affiliates. So this health system was undervaluing its rural affiliates by $9 million. So for a combined $15 million in missed opportunities, $9 million from improper evaluation and $6 million from improved performance improvement initiatives. So again, that has a significant impact on how this health system was viewing these rural affiliates. It really changed how they looked at these folks and that they weren't a drain on the organization. And from this analysis, they now had an actionable roadmap to go and realize the true accretive value associated with these folks. So again, a great story on how a health system was educated on the value of its rural affiliates and created a roadmap to move forward. So process recommendations for new partnerships. What do we recommend you do when you're going through a process of potentially looking for a new partner? Number one is you want to run a competitive process and have folks compete for the privilege of being your partner. Use this time to gather information on your different potential partners. Run a competitive process, knowing that those partners are bidding against one another. They don't know who each other are, but use that as leverage when it comes to negotiations. Use it as a time to educate your prospective partners on your value. Use that as a time to do due diligence on their rural affiliates. Like we've said, doing your research, making sure they're following through on their commitments to their rural affiliates and they have a positive track record when it comes to their rural affiliates. And finally, and most importantly, do not sign an exclusive letter of intent with a selected preferred partner until you have an acceptable term sheet in hand. And this is big. When you sign that LOI and select your preferred partner, a lot of your leverage goes away. So making sure you have an acceptable term sheet with those contractually enforceable terms is really key before moving forward down the line. And because we have a shorter amount of time today, we have a bunch of additional case studies in the appendix of this document. So should you want to peruse and read at your leisure after, those are really great in terms of describing various mistakes or ways mistakes have been avoided with some of the folks that we've had the pleasure of working with. With that, we'll jump into our third and final polling question. How important is it for your organization to explore a new partnership or improve an existing partnership within the next 2 years? Very important, important, we're thinking about it, unimportant, or very unimportant. we'd love to hear from you. So we'll give folks a few seconds to answer that before we dive into our key findings.
And Claire, while folks are responding to that polling question, I think the appendix that Claire referred to is a really great um, way for folks to kind of both understand some of the potential risks and missteps, but also in looking at those case studies, understand how folks turned around some of those situations. So some of
Mm-hmm.
them do end up in a good outcome. Some of them not so much. But they're all examples of the risks that I think Claire and I have been speaking about on today's talk.
Awesome. And thanks so much for your responses. About 36% said very important, 18% important, 30% we were thinking about it, 6% unimportant, and 9% very unimportant. Thanks for that. Right.
Okay, so this really reiterates one of the points I think Claire and I have both hit on earlier, which is sound operations underpin all of your strategic options. So for an organization that is really seeking to remain independent, the best way to mitigate the risk profile associated with an independent strategy is sound operating results. That you're sustaining your balance sheet, you're making investments, your operations are performing in a way that's sufficient for you to invest in the people and technology, all the things you need to do to be a viable health system. So ensuring that you're moving in that direction is really, really important. But the same thing's also true with partnering. Now, maybe to a lesser degree, but the scarcest resource that prospective partners have is, capital is certainly scarce, but even more scarce than that is management, time, and attention. And what scares partners or prospective partners away more than anything is an organization that's struggling and doesn't have a plan and isn't working a plan. So even if your operating results aren't where you'd want them to be, but you're able to create a plan and begin executing on that plan, and that plan is sound, that is a very different conversation, a very different trajectory for that organization than one that is trending down and really is not willing or able or just in a position where they are working to turn that situation around. So having that plan. So understanding your risk profile and the risks of a standalone independent strategy, quantifying any performance gaps, and then developing the strategies and tactics to tackle those performance gaps, and then periodically monitoring performance. If you do get to a point where partnership is an option you want to pursue, that work will serve you well. By the same token, if you decide that continued independence is the most important thing, that work is absolutely essential. So that really is one of the key takeaways here is that all roads start with improved operational performance. One of the things related to that, we're seeing a lot of activity around forbearance agreements. And this is a situation where a borrower or a bond issuer, a bond obligor, has gotten in trouble. They've triggered loan covenants or bond covenants, and this becomes a warning. Often the first step is it triggers a consultant's report when you trigger a loan covenant or a bond covenant. But the next thing that's often involved is negotiating a forbearance agreement with bondholders or with a creditor. And this often comes with certain terms associated with it. And, we've had a number of instances in the last 12 months, one that was really very cooperative with the creditor. This had been a long, struggling rural system, and the focus was on turnaround. They had had a failed partnership process in previous years, not recently, but the creditor and the organization really focused on turnaround, and that turnaround has been successful. Our team was able to go in there and work with that organization and execute a turnaround that has been pretty remarkable in its effect. Another situation was a client of ours that had a forbearance agreement. We were brought in as a result of that forbearance agreement. The lender and the hospital really didn't see eye to eye, and the lender said, you need to bring in a consultant that's going to help you do two things. One, focus on performance improvement, and also explore partnership options. And we were retained to do that. And the outcome of that was really positive for that community and that organization, in that the organization did see improved performance. That improved performance plus a competitive process really led to a very strong proposal and partnership option for them. We're going to talk a little bit more about those specifics as well. So not every outcome ends the way that one did. It's really a high point, but I think when you get performance improvement aligned with a good partnership process, the results really can be quite striking and quite profound. Another situation that in the last year that we've seen is, in this case, second forbearance agreement. The bondholders really took control of the process. So an interested party did an exclusive offer and said basically if it kind of preempted a process, said if you agree to go exclusively with us, we will guarantee that all bondholders will be paid in full. And they effectively kind of forced the hand of the organization. And that process is still unfolding. So whether that's successful or not is to be determined. We always are very wary of prematurely jumping into an exclusive conversation, and for the simple reason that it removes so much of the negotiating leverage from the rural organization and can become quite problematic. So this is the successful result I talked about. This was a struggling organization. It was a good-sized rural community hospital, but they'd had a series of operating cash flow losses, and it depleted their cash significantly. And frankly, we're on track to deplete cash within 18 months at the current run rate. The facility showed very well, but there was still significant deferred investment. And that was becoming an increasing problem going forward. They had no credible path available to them to make those investments. And obviously, the operating results put them at pretty imminent risk. So we were brought in to help with performance improvement and also to help with the partnership process alongside this hospital board and the county commissioners. So the performance improvement worked quite well. $8 million in annual cash flow, got the organization back to cash flow break even, and also into profitability for the first time in years. And concurrent with that, we ran a partnership process that had a result with their preferred partner committing to $130 million over 10 years. So this is a level of investment that this organization was completely out of reach for them on a standalone basis. There was, any scenario imaginable. And so it was a really great outcome. It's a high quality partner. So they were going to defease debt. They were going to help pay for transaction costs, help establish a community foundation, and then had significant capital investment at a minimum level set over the next 10 years. But in addition to that, this partner committed to maintain core services, which was a fairly extensive list for 10 years. Again, that's not a commitment this organization would have been able to keep on their own. And so really from a service commitment, capital commitment, and just the ability, tap into expertise in a high quality organization, really a tremendous win for this community and the organization. So key lessons learned and takeaways from all of this stuff that Claire and I have shared. Again, at the risk of beating a dead horse, operational performance is essential to any strategic option. It's essential to mitigating strategic risk. Time's never a neutral factor. Don't kick the can down the road. Or as one of my mentors said to me many years ago, if you've waited till everybody around the board table is in agreement about what is the right next step, you've waited too long. It's healthy to have some dissent and some good dialogue. You shouldn't wait until the last person is on board before acting. You need to know your value, do the homework, And don't be afraid to share that. There's no risk-free strategic options. I think we've made that point as well. And lastly, if you're thinking about partnering, it's incredibly important to get the process right and identify and vet the right partner without question. Getting the structure right is also important, but as Claire alluded to, contractually enforceable terms that align with your objectives, your needs, your constraints. So again, can't emphasize it enough. Competitive process, vetting and selecting a strategically aligned and partner that is the capabilities and resources to meet your needs, getting a structure that effectively addresses those needs and constraints. If you need capital, a management agreement is typically the wrong structure. Conversely, if you don't need capital and all you need is access to a couple of key advanced specialties, maybe a clinical service line type arrangement could work. But those contractually enforceable terms are the bedrock on which everything rests. If you get those first three things right, but you don't get contractually enforceable terms spelled out in the agreement, it's a house of sand. So that I think is our final slide, if I'm not mistaken. There we go.
Thank you very much, Jeff and Claire. To our audience members, we realized after the webinar started that our Q&A box is not working. So if you did have a question for Claire or Jeff, you can feel free to send that to the host and panelist in the comment box. Or if you would like to follow up with them after this session, they have provided their contact information there. So we'll wait to
Thank you,
see.
Amy. While we're waiting for a question to come in, I wanted to emphasize one of the points that Claire made, and I think she made it well, which is letters of intent. What we've seen is occasionally folks signing a letter of intent that has no deal terms in it. And typically, that letter of intent is structured as a 6 month kind of exclusive period of time where the organizations are going to talk to each other. What you've essentially done, if you do that approach, is you've given somebody a 6 month exclusive without any commitments to your organization or discussion of key business terms. And that can be really challenging. We've actually seen one letter of intent that had no expiration date and no option for the rural affiliate to exit on their own. For those reasons, I don't think it was enforceable. But man, did it tie them in knots for a lot longer than it should have. Eventually,
Yeah.
that prospective partner agreed to release them from the letter of intent. But being really careful about what you sign, even if it's not a contractually enforceable document, putting something on paper, giving somebody an exclusive term that is contractually enforceable is a challenge.
Yep. Well, thank you for sharing that, Jeff. I don't see any comments come in, but again, if you have any questions, Jeff and Claire have provided their contact information for you. And to the audience, thank you very much for spending part of your day with us and for your continued commitment to serving the rural communities across the country. Today's conversations focused on many of the long-term strategic decisions that rural or healthcare organizations are navigating today, including facility planning, partnership strategy, capital investment, and organizational sustainability. Across each session, we heard practical examples and real world perspectives from leaders working directly alongside rural hospitals and healthcare organizations every day. As a reminder, when you close out today's session, you will receive a brief survey pop up. We truly appreciate your feedback, and it should take less than 1 minute to complete. We hope you'll join us again tomorrow for our final day of our 2026 conference. Thank you and have a great day.